Welcome to another episode of A Gut Feeling. Thank you for joining us. We are continuing on with our peptide series, peptide podcast series. We're still a gut feeling. We're not a peptide feeling yet, but maybe soon enough. Dave,
We're
how you doing
making
today?
we're making a slow transition towards a peptide feeling.
We'll change one letter at a time each week. And before you know it, we'll be sitting in a peptide feeling. So today's episode is a little bit different to the other peptide episodes we've done so far. So far, we've covered different topics, stuff like skin and gut health, and we've covered particular types of peptides. We've done all the growth hormone peptide, related to body composition, and we're getting a lot of questions online, and there'll be a lot of questions like, okay, maybe you've covered XYZ peptide, but what about these issues? Can I use it if I've got this problem going on? Or, is there a concern with this? I heard, safety issues around cancer, or I heard I can't use it if I've got endometriosis, or I heard that it's associated with these side effects, or I heard that there's no human studies, and it's all just an animal study, and how do I know it's safe? And all these
Or the
concerns and
famous
these
or the famous quote, insulin and glucon-like peptide 1 receptor agonists are the only peptides
yeah.
with human trials.
Yeah, yeah.
Like yeah, there's just too much of this, like
And I get
all
why
over
people are
like social media.
confused. I get why people are confused because there's some just absolutely wild claims that are being made. And I guess our goal today is to dispel some of those claims. And look, some of them, maybe there's some truth to some of them, and we're going to talk about where that might be. And some of them are just entirely fabricated. And, I hear all the time from people who are actually often researchers or doctors themselves, not researchers or peptides, but in other fields. And I'll see people making claims like no peptides have human data behind them. And it's like, well, hold up, that is verifiably false, and you can do a 2-second Google search and find that out. So our goal
Well, and
today,
even the one, which obviously we're going to go into, where people just say, well, one of the biggest concerns would be around the safety and the efficacy. And I'm not saying I'm against someone stating that they're concerned about the safety and the efficacy, but you need to, so elaborate
don't
what
they call you
could,
Daredevil Dave? you're you're all against safety, I hear.
well, the thing is like, okay, that don't you find with like like social media that people are just saying these statements and then people go, oh my God, there's the safety and the efficacy, but then they don't even elaborate on what the safety and efficacy issues are around that particular peptide. I mean, they're just stating that they might have some concerns around it, but they're not even going into the detail around it. And that's a big issue.
Yeah, yeah. So it's a efficacy issue of that statement. So we are going to cover. There's a lot to cover. So this is not going to be an
That's going
exhaustive.
to be a bit of a fiery one. Yeah.
Well, possibly. Who knows? Who knows where this is going to go? But what we do want to look at is there human data in peptides? And then we want to look at, is the human data showing efficacy and or is it showing safety concerns? And maybe we'll chuck in some comparisons there to medications that are being used as well, just to give you guys a bit of context. And then we want to cover a couple of questions around, well, what if you do have some of these other issues like cancer or endometriosis or PCOS or whatever else that people are being told you can't use peptides with? So that's a roadmap. Will we get there? Who knows? Join us to find out. So to begin with, I guess we'll talk about the human data. Yeah, is that where we want to start?
Yeah. Human subjects. Because obviously that's a big, once again, a big clickbait title.
It is a big one. And, in case people don't realize, like most of the content that I'm seeing that is directed against peptides, it's coming from ChatGPT. I don't know if people realize that. So, every time you see a post that says something like, when you buy a peptide, you're not just buying a peptide, you're buying a production line or a supply chain, or like all these, like, it's not this, but it's this. All those posts are purely ChatGPT just dribble, right? Like
Just like a talking point. Yeah.
yeah,
Without
and it
any
doesn't mean it's
substantial
based on
information behind it.
Exactly, exactly. So there's a lot of stuff being spread online which is not actually based on anything factual. It's just someone is going to ChatGPT, presumably saying, "I think peptides are dangerous. Write a post for me about why they're actually bad for you." And that's the kind of stuff that's coming up. So one of those big claims is there's no human data in peptides, or maybe there is some in GLP-1s and in insulin, but that's about it. So I'm just going to cover a couple of I guess, points around how long we've actually got human data going back for some of these peptides. And then maybe we can talk about the quality of some of that data, or we'll pick up on a few specific peptides. But let's just start with how old is this human data? Because again, people sort of believe that this is really new. Peptides are new. We haven't been studying these for long. Now, if we look at things like GLP-1s, and we haven't done a episode yet on GLP-1s, and we will. It's one of the next episodes we're going to do. But obviously, people tend to be a little bit more open to GLP-1s because some of these are FDA approved, and obviously some of these are prescribed, and everyone knows someone using a GLP-1. So people tend to be a little bit more open-minded. But if we were to look at the data, the human data on GLP-1s, which, people are pretty comfortable using, we go back to things like liraglutide, which isn't even used anymore, really. And, that data is going back about 20 years, right? As far as human published trials. Okay. So, yes, there might be some that predate that, but generally speaking, for GLP-1s, we're looking at about 20 years of data, which, is pretty good, right? Like, that's nothing to sneeze at. But if we look at something like tesamorelin, we've got over 20 years worth of data. Okay, again, tesamorelin is FDA approved. It's used in HIV/AIDS for muscle wasting. So there's this again is a peptide that has a lot of safety data behind it. But my point is, even these things that we're happy generally to accept, as safe and have been approved and whatever else, we've got other peptides with data that exceeds that, right? If we look at something like melanotan, okay, so we obviously it's melanotan 1, melanotan 2. Melanotan 2 tends to be used a little bit more commonly. It's a little bit less selective as far as the melanocortin receptors that it's working on. We've got data, human data in melanotan 2 going back to the mid 1990s, right? We've got about 30 years of data on that. And that's human studies showing efficacy, showing that it's effective in that instance. That human data is looking at sexual function, it's looking at erectile dysfunction in men and showing efficacy, showing something like 87% of melanotan doses were associated with improvements in libido and sexual function.
Well,
So, yeah.
sorry to interrupt you, but I mean, I think you might have put up some information around this. Like, just even, I believe it was in regards to like thymosin alpha 1, which obviously
Yeah.
we've done a podcast talking about that, okay, which is
Yeah.
a
I mean, there's
peptide
safety
fragment.
trials going back to 2001, I believe, in TA1.
Yeah. So I mean, yeah, that's what I wanted to say. That's even over like over 20 years of,
Yeah. We're talking a quarter
research
of a
and
century in this stuff.
yeah, yeah.
It's just
So
ludicrous to say that this studies these studies are new, and there's no long-term data in these things. Like, okay, we can make an argument about how large some of these studies are, fine. But, we're talking, a lot of these, we're talking safety trials, phase 1, phase 2 safety trials, even GHKCU, we've got data going back to the early 90s in
mm,
GHKCU. There's studies going back to 98 where they're using it in women. I think that I believe that around the eyes study, I think that was around 98. There was one on thigh collagen synthesis. So again, we've got over a quarter of a century of data in these peptides. Some like, I believe DSIP, deep sleep inducing peptide, I think we've got about 40 years of data in that.
yeah, yeah,
So
yeah.
it's yeah, there's a long list of human studies in these peptides. Now, I think where this gets maybe misconstrued is if we look at something like BPC. Okay, we're actually pretty limited in that. We've got
Mm,
uh, a, a, un, a phase 2 ulcerative colitis study, which is very hard to access. And I think I forget how old that is, about 10 years or something like that. But there's only sort of, it's alluded to in conferences, but you can't actually access that study. So I understand. And then we've got like a retrospective study done in people with knee injuries who are using either BPC or TB4 or TB500 actually. And I understand that we're limited there in human studies, right? But that is one example. And what people are doing disingenuously is taking BPC and saying, look, there's no good quality studies, human studies in BPC. Therefore, peptides don't have human
Yeah,
studies.
just applying that, that one example just fully across the board. Yeah.
Yeah, exactly. So,
So I mean, obviously, all so we could say, that's been, you can myth bust that ultimately.
yes.
The
Yeah,
other
yeah.
one,
Is there human studies like claim? There's no human studies in peptides, like myth busted. I didn't even mention like CMAX, C-Lank. They've got over 20 years of human data. Obviously LL37. We did a podcast on that. That's got over 10 years of human studies in it. We've talked about thymus and beta 4. It's a better question, honestly, would be show us peptides that don't have any human studies. Honestly, that would be a harder challenge than finding human studies in the peptides that are being discussed.
exactly. The other within this sort of conversation, the other one that would, I mean, I think it gets brought up as well. Okay, would be okay. Well, I mean, I don't know if too many people are acknowledging that there are human trials. Okay, but the other one would be saying, well, there's not enough human trials,
Yes.
and there's not enough, human subjects. So there's not enough, your healthy volunteers and whatever that might be. Yeah, okay.
Hmm.
So one thing I did want to talk about, and we've talked about this, and we've tried to sort of make sense of it. Okay, is okay. What is the if we're looking at something getting FDA approved,
Hmm.
what's the process? And I'm not saying that I fully understand everything that is required
Hmm.
and what is entailed in this process, but what is, if it comes to the amount of healthy volunteers and human subjects, what does that sort of like roughly look like? Does that sort of make
Hmm.
sense what I'm saying? Yeah, like
Yeah,
in
yeah. I
terms of
mean, broadly speaking, what is that process that is
yeah,
required?
yeah, okay. So
Yeah.
and so for example, to become FDA approved, they might say, well, okay, we've sort of got like this, phase one.
Yeah.
And phase one would be,
But
well, we've
obviously, there's stuff that's going to happen before that as well, right?
yeah,
Like,
yeah, yeah,
before
yeah.
you can test in humans, there's obviously got to be, good animal studies showing what the
Yeah, like
mechanism of action
obviously
is,
marine
the
models, yeah, okay, which
efficacy.
is
Yeah,
like, rats and mice and
yeah,
rodents and so forth. Yeah, so, I mean, it's obviously got to start there, yeah, okay.
yeah,
So obviously maybe I'd sort of fast tracked this
yeah.
process, yeah. But okay, so now let's say we're getting to the human subjects and we're getting to the human trials. Okay, so we've got like this, sort of phase one where there's just going to be like these small studies.
Yeah,
Yeah.
there might be,
Um,
30 people and they're just
yeah.
looking at
I mean, that could
safety essentially.
vary. I mean, obviously, trying to fully understand what that number would be, I would say seems a little bit murky. Yeah.
Yeah,
Okay.
but
But it could
it's
be,
usually going to be a fairly small.
yeah. So it could be like, between 20 or, 100 healthy volunteers, whatever that might be. And so then you move to the phase two. And now it could be, oh, well, you need about, one, two, or three studies. And now it's getting into higher amounts of patients and individuals. And okay, now we're looking for, anywhere between 100 to 300. And they're evaluating the efficacy and the side effects and the adverse events and so forth. And then you get to phase three, and now these are larger studies. And I think I looked at some stuff where they say you might need like two large studies. And so this could be, now we're getting into 1,000, 3,000 human subjects. But
And at this point, we've got decent safety data, right? Like at this point
yeah,
now, what we're
yeah,
looking at really is there like a large enough magnitude of benefit, really?
yeah. So one thing I want to bring up is because then people would say, well, we just don't really have that when it comes to a lot of peptides, we just don't really have a lot of these a lot of these clinical studies. There's not a lot of human subjects
Mm.
and so forth. Now I've used this example previously, and that's around TA1, okay, which is 28 amino acids. But remember, I talked about a study that I found, I think it was 2023, I'm pretty confident around that, where what they were doing is it was a study to assess the safety and the efficacy of TA1, thymosin
Mhm.
alpha 1. And so it was just a comprehensive review where of the clinical studies, the big point that I want to get across is just around the human subjects.
Mhm.
And that was 11,000 human subjects.
Yeah.
Yeah,
So pretty
so
substantial.
pretty substantial, yeah. Now, where this creates a lot of murkiness is, okay, so if this is sort of like a framework, then you look at something like TA1, well, there are FDA restrictions on TA1.
Mm.
Now, obviously, we're going to get into safety, efficacy, okay, but the point that I want to get across, okay, well, there's 11,000 human subjects, and that's across in like that comprehensive review of the clinical studies was across infectious diseases and cancer and autoimmune diseases and COVID-19, all that type of stuff. Okay, so that was treating various conditions. Yeah.
Mm.
Now, where you know, this starts to become a little bit murky is what they found within that study is that it was well tolerated.
Mm.
It was the safety and the efficacy was beyond what the specified conditions were.
Mhm.
And now you've got like a total of like 11,000 human subjects.
Mm.
And there is still a FDA restriction on that. Even though within that study, they said that the FDA restrictions appeared to be unfounded.
Mm.
And I've told you this before, that they actually flagged urgent attention and intervention because they found that peptide was a life-saving peptide. And that's really around the cancer aspects, which
Yeah.
we are going to talk about that. Yeah. But you understand my point. Yeah. Okay. Is like this,
Mm. So
what
I
is it?
don't know the answer to this. I might be wrong, but I wonder if maybe some of it, because we've talked in the past on episodes about how often when we look at a peptide, it's very multifaceted, right? There's not normally just one mechanism. And usually when a medication is approved, it's approved, with a very linear scope of use. And I wonder if something like TA1, you look at it and it's like, well, this data, like you just said, it's done in a whole range of infectious disease. And so I wonder if there's a limitation where it's like, hang on, do we even have a framework for what it looks like to approve a quote unquote medication that is so multifaceted? It's not just, because you look at the stuff that has been approved, you look at Tesmorelin or you look at, even the GLP-1s, it's like, okay, well, they'll be approved for type 2 diabetes or for, even you look at like PT1 for one, who's it approved for? It's approved for post-menopausal women with hyposexual desire. And it's like, that is so linear. The studies that we have in these peptides is showing that its efficacy is beyond just this very
What
small
can I?
group of people.
Yeah, can I add to that? Because I'm always vocal. One of I'd say my favorite peptide, and I think it's the most versatile and diverse peptide is thymosin beta 4. And obviously, we've mentioned this before. It's got to be a TB 543 AA. Not that we're saying you don't get benefits from just the
Mm.
TB 500. Yeah, but
But TB500 would be an example of a peptide with basically no human data behind it, as opposed to TB.
exactly. Yeah. So, but the where this gets just even more murky is that you've got like now, yes, I would probably admit that you're not getting the same number when it comes to human subjects, yeah,
Sure.
as something like a TA1. But okay, maybe it's in the realms of hundreds of human subjects. I don't know the exact number, okay, but there's still hundreds of human subjects. So it's still reasonable, yeah. Because a lot of things, you'll just look at it and you're just getting a lot of marine models and animal studies and all that type of stuff. Yeah, okay. Well, at least there is hundreds of human subjects. Yeah. Now, my point around this one is that thymosin beta 4, there was phase 2 trials for dry eye disorder. And actually, you know what? I think they initiated like phase 3 trials around that.
Mm.
Now, but obviously there's huge restrictions around thymosin beta 4. Yeah. Now, even around myocardial infarction. So for people who don't know what I'm talking about there, we're talking about heart attack. Yeah. And infarction is like death to tissue. So that would be death to tissue in the heart. And I'm a big fan of thymosin beta 4 because it activates endogenous cardiac cells. So it helps with CD90, CD117. Layman's terms, this is myocardial regeneration. So we're talking about heart repair. Well, that, from my understanding, was like phase 2. I think it was phase 2, might have been a little bit beyond phase 2. But this is what, like, I think you can get like phase 2A or something like that. So it's obviously, it's progressed.
Mm-hmm.
And there's still restrictions
Yeah.
around that. Yeah. Even topical, there's pretty good, like I think we've spoken about that in other podcasts around thymosin beta 4.
Yeah.
There's pretty good human trials for wound healing with thymosin beta 4 as well. And then once again, we're still talking about these restrictions.
I mean, there was I'm not familiar with the study you're referring to with thymosin beta 4, but there was a study even earlier than that, a 2021 study, a phase 1 safety trial for the same thing you're talking about, myocardial infarction. And they concluded, this is 5 years ago, they concluded that it was safe and well tolerated. And I think I believe the exact words were, it's suitable to be used clinically for myocardial infarction.
Mm.
5 years ago. And, some of these, like TA1, like you said, some of that data is going way beyond 5 or 10 years. Yeah. And so why do we have these safety trials that are showing in humans that there's there's effectively no adverse events or toxicity being identified? The researchers are saying, hey, we really should be using these, and they just don't go anywhere. And I might be wrong here as well, but this is because I get people asking me this all the time. They're like, when is BPC going to be studied? When are we going to get data on this, blah, blah, blah. And I look at something like GLP-1s, and obviously GLP-1s, these are synthetic. Okay. So you look at something like, retatrutide or tirzepatide or whatever, these are synthetically produced peptides. But then we look at something like BPC 157, even, thymosin beta 4, like what we're talking about at the moment. And these are naturally occurring peptides. Now, yes, obviously you can synthetically produce them, but you can't patent a naturally occurring peptide.
Mm.
So we're not going to get studies on BPC 157 or on TB4, really, because who's going to put money into studying a peptide, which essentially it's like it's basically open source, right? Like anyone can use it. You can't patent that thing. So that presumably that's a big problem here. That's why we're not seeing more of these studies and more of this money go into these peptides that are being shown to be efficacious. Is that?
And can I also say, it just seems like a no-win situation. So what I mean by this, so I think like when we talked about growth hormone releasing peptides, yeah, and we talked about, CJC 1295, which is the 30 amino acid peptide. Now, the point that I want to bring up around this is because obviously they were looking at that around sustained increases in growth hormone, IGF-1 levels, and so forth. Now, my point is, in the research, it was well tolerated. Okay, it was safe in the research, but it's still questioned.
Mm.
And don't you even find even you can get a peptide that is FDA approved, like you mentioned the testosterone, which is the growth hormone releasing peptide. So that's FDA approved, and yes, obviously around the stuff with HIV and abnormal fat redistribution, and obviously we've spoken about that. But then you get people in these talking points around peptides, and then they can even question some of these ones, yeah, and they're FDA approved. Do you know what I mean? Like, do you know what I mean by in terms of it seems like it's just a no-win situation?
Yeah. 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 I again, I don't want to name names, but I'm going to name names. No, I'm not going to name a name. But there's a large a large, what would you call it, a data, not data, publication review, like a scientific journal review, essentially, research review. And it's very well known, and I would say quite well respected. And its main sort of focal point is around exercise. Okay, so more around hypertrophy, muscle physiology, maybe some nutrition. Okay, and again, very very well renowned. And they talked about peptides recently, and they put out a an article saying essentially that there's no human data behind peptides, which obviously verifiably false. And then they said they said that tesamorelin, or maybe they said ipamorelin. They said ipamorelin, BPC, and they named one other peptide. And they said these peptides have not been shown. Quote: they said these peptides have not been shown to improve, and they listed things like libido, or there's a whole list of symptoms that they improved, or conditions that they've been shown not to improve. And they obviously neglected to mention that other peptides have been shown to do that, like PT141 or melanotan-2. And there was no mention of these other peptides. They've only examined two or three different peptides and then said, therefore, based on these peptides, peptides don't do X, Y, Z.
Because you
And
mentioned, I think you mentioned at the start, the active metabolite of melanotan too. I mean, what was it? That was 1.75 milligrams, and that was in perimenopausal women.
yeah, well, we've got
Yeah.
data with melanotan-2 showing sexual function increases. I think you're talking about the PT141 there, but melanotan-2 going back to 1998 or 1996. And like you were saying there with PT141, that's FDA approved. We can't say that peptides don't do these things. And I'm just like, I'm there scratching my head. I'm like, you're basically saying that what? Acne medication doesn't treat headaches, therefore we don't have any medication that helps headaches. It's like, okay, maybe
It's a
acne
good,
medication doesn't do that, but
it's a good
ibuprofen does that.
analogy. Yeah.
I'm just like, what is happening? Are we all losing our minds when it comes to peptides? I don't get this. Anyway,
Yeah,
that's
well,
my little.
I've heard you say this, and I can only reiterate this point: is you know, I mean, it's just really just stop supporting people where you know when they're just putting out when they're just putting out information that is just like a statement,
Yeah,
and like we always say that there's a lot of nuance here. Generally, people don't like nuance, but that's what you need to understand. And if someone's just like it's just a talking point. Is that just clickbait?
yeah,
Probably the answer would be yes. Yeah.
yeah. So our next point is around safety and efficacy. Now,
Here's another. Well, this is, this can be myth busted
mm,
quite easily, I would say.
mm, yeah, and I don't even know where to start with that, because what you could do, where we could start, is by looking at, well, in these human trials that we've got, in these safety trials that have been done, what are the adverse events that are being identified? And I don't think we need to spend a lot of time on that, because by and large, it's kind of the same thing in most
Well,
cases,
well
right?
haven't we already? I think we sort of like talked about, even when we were just talking about the human subjects. I think we are just talking about the like the peptides that we were mentioning being well tolerated. Like you remember how I said with the TA1, the
Mm.
safety and the efficacy was like beyond the specified conditions.
Yeah. So like TA1, like what are the adverse events? We're talking like injection site irritation. Yeah. Like as far as I'm aware,
Yeah,
that's like
like
the
in
main.
terms of documentation. Yeah, okay.
Yeah.
I'm just saying, like, if I look at the documentation, it it's generally going to say well tolerated,
Yeah. Yeah.
and it also just demonstrating significant effectiveness and really effective immune modulator. What I'm saying is, it's just like I'm saying, where is the safety and the efficacy issues with that?
Yeah.
Yeah.
Yeah. I
And
mean,
even like
broadly speaking, yeah, you
you
go.
go, you go.
Well, I was just going to say, like, broadly speaking, if you do categorize these peptides as the main sort of adverse events they're seeing. If we look at things like, PT1 for one, melanotan 2, even to an extent, some of the GLP-1s, like the main side effects we're seeing there are nausea, um, and like flushing. And then with melanotan and PT1 for one, we see, and particularly PT1 for one, a potential increase in blood pressure. And they seem to be the main documented adverse events. When it comes to GLP-1s, obviously there's a few additional things, and nausea still is the main one, constipation, obviously because it's slowing down gastric motility, but they tend to be the main documented adverse events. Yes, there might be
And then
some
if we
stuff
get
around.
into the category that we already broke down, I think we might have mentioned it. So maybe I'm sort of parroting the information again. But if we look at the sort of gut peptides, yeah, that BPC 157 and obviously thymosin beta 4, TB 500, 43AA, and GHKCU. I mean, if we're talking about adverse events, a lot of time it's in regards to what? Because like this would be in regards to injectable. And a lot of time it's what? Like injection site
Yeah,
reactions?
that's
Like
exactly it.
like
That's
bruising
generally
and
the thing we're
itching
seeing.
and swelling, okay? And like I'm just going, well, that's so minor, yeah? Um and yeah, I mean like the and then I think we might have talked about this in another podcast, but if people are talking about, and I think you will probably have something to say around this, if people are talking about more severe symptoms like gastrointestinal distress and maybe like neurological, is there more question marks around glucagon like peptide 1 receptor agonists in
Mm,
regards to that? Like and once again, now we're getting into the realms of like, so is this more to do with like FDA approved?
mm. Yeah.
Yeah.
Yeah. I mean, that's a fair point. Like a lot of these peptides that aren't even approved, they're the ones that have basically no adverse events documented. I mean, with GHK, I want to read this out. There's a study, 2018 study, regenerative and protective actions of the GHK-CU peptide in the light of the new gene data. And the study starts with this. It says the human peptide GHK has multiple biological actions, all of which, according to our current knowledge, appear to be health positive. All of the biological
It's,
actions of GHK appear to be health positive.
but then I hear people just like, focusing on like, oh, there's, like sometimes people can get like the injection site reaction where they get a bit of almost like a urticaria, which is
Yeah,
like
a
a
little like
rash. Yeah.
histamine
Like
response, right?
hives. Yeah.
Yeah,
Okay. Like hives. And I'm like, that's not me downplaying that. Yeah. Okay. I'm just saying, well, that's relatively minor. Yeah.
yeah,
Or the bruising, yeah.
yeah.
Um, yeah, and we don't obviously need to go into, like, all the benefits that you're gonna get from, like, GHKCU because I think
Well, maybe we should. This is what, let me just read this line out. GHK's ability to improve tissue repair has been demonstrated in skin, lung, connective tissue, bony tissue, liver, stomach lining. It's been found
you got honey on the brain,
honey
mate.
in my mind. GHK has been shown to possess powerful cell protective actions such as
You're
multiple,
waiting for the honey peptide.
the honey peptide. That's our next podcast. Multiple anti-cancer activities, anti-inflammatory actions, lung protection, restoration of chronic obstructive pulmonary disease, fibroblast, suppression of molecules thought to accelerate the disease of aging, such as NF-kappa B, anti-anxiety, anti-pain, anti-aggression, DNA repair, cell cleansing. I mean, goodness. And it also what? It modulates like 3,000 different genes. I mean,
Well,
gosh, show me a
and
medication that
we'll get
does
into
this.
this a little bit more because it's which I don't know if we covered this in the gut peptide podcast, maybe, but and then maybe I'm sort of like answering a question that was sent to you around like peptides. But there's a thing called long interspersed nuclear element one, line one. I'm going to mention it now because you've sort of opened a can of worms here. But I actually did a fair bit of research around this in regards to this was to do with like the mRNA vaccines. It was actually Moderna and Pfizer. There's like Lund University in Sweden that actually showed there was an increase in line 1 expression, which that can actually be a major hallmark of cancer. So line 1 RNA, and so if you get like this protein overexpression, it's related to things like cell death and DNA damage and promotes tumor progression. Now, this is where GHK is very interesting for me, because I think you've already mentioned it, because GHK can reset genes of diseased cells
Mm,
and I think that's been from patients with cancer, lung disease, to a healthier state, basically. So the GHK is stimulatory for the gene expression of DNA repair genes. This
mm,
is like increasing DNA repair activity.
mm.
That's pretty, that's pretty substantial. Anyway, I probably went there a little bit too early, but it's the
I
cat's out
mean,
of the bag.
you mentioned how TB4 is your favorite peptide. Like for me, GHK is my favorite peptide because, what you're saying there, just with genetic impact it has, it's just unbelievable.
Mm.
That list of things I just read out. And the fact that you don't become desensitized to it.
Yeah,
There's
that's
no
a big thing, isn't it?
process
Yeah.
for that. So who is it not good for? I don't know. Anyway, one thing I did
Uh,
want to mention,
Well, there's something. You go first. There's something I want to
well,
mention back on the safety and the efficacies.
yeah, well,
Like
I was going to
this.
go back to that as well. I was just going to
Yeah.
compare to a couple of medications, but you jump in with what you've got first.
This is a bit of maybe it might be a little bit more of a like a rant. So okay, so if we're looking at, and once again, it's hard for me to fully understand this, yeah, because it seems like there's rules for certain compounds, and then there's other rules for other compounds, yeah.
Mm,
And so when we're talking about safety and efficacy issues with a compound, there would be aspects around they would they would issue like a ban. There would be like, okay, they withdraw approval around this. Obviously, this is in relation to like, pharmaceuticals. Yeah. Okay. And then they restrict the use.
mhm,
Now, one thing I mentioned to you like previously is that, okay, if there are potential adverse events, side effects, like what they do with medications is there's what's called a black box warning. So they put a warning on the label. And also, if you think about it, like a lot of cancer medications, they are frequently withdrawn. I mean, I don't know the stats around that, okay, but that I think that's because obviously there's some issues around the safety and the efficacy.
mhm.
The point that I want to get across is that, okay, so why for whether if there's some particular like pharmaceutical medication, can they have this warning on the label, just talking about, well, there could be this adverse event, and obviously the list
Yeah,
can be pretty long there, yeah.
yeah,
But then if there's just like one question mark around, okay, this could cause nausea, or there could be like urticaria and rashes. I know this is a problem.
yeah,
So
yeah.
why can you not even have like a black
Which,
box
I
warning?
don't know that that's coming from the legislators and regulators. Like that's to me seems to be a question for people who are online talking about peptides, right? Because I think there's a multitude of reasons as to why these things aren't being approved and why there's not, phase 3 studies being done. And like I said, I think money is a big part of it and whether people can patent these peptides. But why, if people online are saying, well, this has been shown to cause, whatever, maybe some people are getting nausea or there's a transient increase in blood pressure from, about, 8 points, or there's a slight increase in heart rate, or, whatever some of those relatively minor concerns are those same people coming at it saying, well, therefore these medications with this long laundry list of adverse events that you've just mentioned, should those medications therefore not actually be available to people? And there's no
Exactly.
continuity in that argument. No one is saying, yes, we should therefore be taking ibuprofen and aspirin off the shelves.
What's it like? And maybe this is just if you look at some of these studies, I think they were from the 1990s. Yeah. Okay. So, and I think there's a bit of nuance here. But with some like NSAIDs, like non-steroidal anti-inflammatory drugs, okay, so ibuprofen and aspirin comes in that category. It can be estimated. Now, this is based on the US. It can be estimated up to potential like 16,500 annually can die from that, and that could be like obviously there's numerous factors within that. Okay, overdose but
Mm.
GI bleeding is one of the big things.
Yeah.
Yeah, that's that's crazy. Yeah, okay. And I've actually looked at some stuff where it can be anywhere between 10 to 25% of patients experience adverse drug reactions. And the number of reported drug reactions, that is steadily grown since about 1978.
Mm.
Like drug-related hospital admissions. And then now we're over here saying, oh, well, you could get a rash.
Yeah. Yeah. Yeah, I mean, if we compare some of these to their, I guess, like medical counterparts, I mean, you look at something like melanotan 2, or PT141, like I mentioned before, the adverse events that they're associated with, and nausea, flushing. I mean, what reduced
And
appetite?
wouldn't you say like around this, we would probably acknowledge that they might be the ones that actually have maybe a slight more um like a slight larger amount of adverse events and
Yeah, I
side
mean,
effects.
adverse events
And
relatively common, but my point is compare that to Cialis or compare that to Viagra. What do you see? What are the side effects of those
yeah,
medications?
exactly.
Headaches, blurred vision, facial flushing, uh, nausea, this back pain. I mean, the same adverse events, but along the list, right? I mean, again, look at something like BPC, adverse events associated with BPC. I mean, as far as I'm aware, we don't really have any that have actually been documented. I mean, there's
Okay.
speculation,
I mean, even
but
even with like thymosin beta 4, I mean, outside of obviously what we've already talked about, like injection site, reaction. I mean, I think I've come across, minor documentation, a bit of lethargy.
yeah, and what are their counterparts? I mean, look at something like thymosin beta 4 or even TA1 or BPC. The medical counterpart is probably going to be some kind of corticosteroid, right? And what are they associated with? Well, issues around blood pressure, issues around what osteoporosis. I mean, far far more significant things than TA1. Issues around, obviously you look at stuff around then catecholamines and stress hormones and even fluid retention, weight gain. I mean, again, none of this stuff is
I mean,
documented.
and we're not even going into the significant damage to the gut lining. Yeah.
Yeah,
Because like, you start going down this, like NSAIDs and SSRIs and opioids. And, I think we've spoken about this in another podcast, but they like impact localization and also they cause a downregulation of E-cadherin.
mm,
And a loss of E-cadherin is a contributor to the progression of cancer.
mm, mm, yeah.
Anyway,
And then
I mean,
GLP-1s.
we could keep on going forever, like talking about that. Yeah.
Yeah. And, GLP-1s, like I mentioned before, obviously nausea, then you got stuff around constipation, for some people, diarrhea. I mean, and I guess you could potentially put deficiencies into that as well, but is that a result? Like, that's really just an outcome based off the reduction in dietary intake. Yeah, it's not like the GLP-1's causing the deficiency.
Mm.
But, contrast that to maybe the best alternative I could see pharmaceutically is maybe something like metformin. And, metformin, I would say, is a relatively inert pharmaceutical, but what's it associated with? Nausea, diarrhea, abdominal pain, B12 deficiency. I mean, the
Isn't there,
same type.
maybe some potential issues around coenzyme Q10? I'm not 100% sure on that. Yeah, but um, I think there might be. Yeah.
And, ultimately, a lot of these, a lot of the adverse events, if any, from peptides that have been documented, generally speaking, are relatively similar to what their current pharmaceutical counterpart is. So, when people are saying, "Oh, the safety is the issue here," it's like, well, for which one? And we have to be specific
Mm.
as well when we are talking about peptides. Which peptide are we talking about? GHK? I mean, like I read before, we haven't noted any negative things apart from at an injection site, and you don't even need to inject GHK. So, show me the safety concern with GHKCU. Like, I don't see it, and the data doesn't see it, and the animal studies don't see it, and the human studies don't see
And
it.
that's what I said right at the start. Okay, if someone's bringing up, well, there's concerns around the safety and the efficacy, and that's all they're saying, and they're not elaborating on that. I mean, that's a concern. Yeah,
Yeah. I mean, it would be akin to just saying medications are a concern because of the safety data. Like,
yeah.
okay, some, some maybe not. It depends. It probably depends on which one we're talking about. It's the
Mm,
same thing with peptides. And I don't want to make it sound like there's no possible side effect of any peptide. Obviously, I've been vocal in the past about some of the GLP-1s. Reducing gastric emptying, reducing gallbladder contraction, that can potentially lead to small intestinal dysbiosis. We've got some preliminary data showing that that's possible. So, yeah, and again, ironically, these are the ones that are FDA approved. Not that that seems to mean anything, but I do think that the other data on GLP-1s is so compelling with so many other benefits that I think there's probably ways we can mitigate some of that risk
mm.
of delayed gastric emptying. So, I'm again not saying that there's no possible side effects of any of these, but are we blowing it out of the water a little bit out of proportion with, oh, I don't know what a good example is, but when some of these have absolutely no documented adverse events, is that really the talking point? Is that, the criticism we should be making?
Exactly.
Anything else on safety or efficacy you want to mention?
Is it a segue into, because this would be like obviously one of the safety concerns
Yeah.
that gets brought up around peptides is around cancer.
Yeah.
So I think it's a
Well,
segue into that.
even more broadly, so one of the most common or the most common questions I get is, can do peptides cause cancer? That seems to be the question. I've heard they cause cancer. And particularly that's around BPC 157, but generally, I guess more broadly, people are just concerned about peptides in general. And then the extension of that question tends to be, well, if peptides, quote unquote, cause cancer because they're increasing angiogenesis, then any condition that could be worsened due to increased angiogenesis is probably also, a bad mix with peptides. So then people start to say, well, what about if you've got endometriosis? What about if you've got PCOS? Both of these could be worsened by angiogenesis. Angiogenesis basically just being increased blood vessel formation, right? So if we're providing more blood flow and more nutrients and more substrates to, essentially damaged or problematic tissue or whatever, are we potentially feeding tumors? Are we potentially exacerbating tissue growth? Are we, worsening these health conditions? So that tends to be a very common question. Yeah.
Yeah. So, because obviously it seems like there's two parts to that. Yeah. So one part would be, okay, so, um, are the peptides like an issue around the cancer? I mean, one thing that I want to bring up, well, there's certain peptides that ha- you know would have benefits around cancer. Yeah.
Yes. The
Um,
documented data we have at this point in time suggests that there's benefits. Yeah.
yeah. But that once again, that's not me saying it's a cure for cancer or anything like that. Okay, so I'm talking about benefits around cancer. Now, one we've already mentioned, which I love the data around this particular peptide. Okay, is TA1 again, thymosin alpha one. Now, now, if you look at, which I think I mentioned in the podcast talking about TA1, there's stuff around like using that to treat chemotherapy-induced immunosuppression, and even modulating and partially normalizing T lymphocytes. Because if someone's got cancer, the T lymphocytes they just tank, yeah, and actually helping with the T lymphocyte number and function, and also there's stuff around TA1 suppressing proliferation and inducing apoptosis, which is programmed cell death, again in breast cancer cells. And the big thing with TA1 is that it targets toll-like receptors. And So if you look at, there's one called toll-like receptor 4, and I think I've spoken about this before. And you can look at like toll-like receptor 4, and there can be a potential link there with things like sarcoma, it's like bone cancer, breast cancer, and lung cancer. Yeah. So now, and they've actually shown that toll-like receptor 4 can promote metastasis in breast cancer, and the toll-like receptor 4 can promote migration of breast cancer cells and activation. Now, my big point is that thymosin alpha-1 targets toll-like receptors. So that's one. But we can keep on going, yeah? We can keep on going here, because I already mentioned the stuff around, GHK. Now, I mentioned the stuff around like the Lyme-1 expression, which is a major hallmark of cancer. But there's also like GHK, so you increases the expression of what's called the P63 gene, or the P63 protein, positively, not negatively. Yeah. And the P63 protein, the metabolism, plays an important role in epithelial stem cell regeneration. That's stem cell therapy. So like with GHK, there's sort of like these multiple anti-cancer activities, anti-inflammatory actions. It goes, that's another one. Yeah. Does it stop there? No, because I think I don't know if you've already mentioned in this podcast, but I think you mentioned, we definitely would have mentioned about this. I think when we did the skin peptide podcast, and that's around melanotan 2. Yeah.
Yeah. Or melanotan 1, both.
Yeah. Well, like I remember with the stuff with melanotan 2 was around tumor suppressive mechanisms, like decreasing cell migration, proliferation, tumor growth. Yeah. Was that in regards to like being like a therapeutic strategy for melanoma?
Yeah, well, I think so. I mean, the melanotan 1, so obviously with the melanocortin receptor 1, there's been data showing that basically activated melanocortin 1 is associated with reduced, UV damage, reduced chances of developing into melanoma. So, and even like people with mutations there around melanocortin 1, there's some issues there around development of skin cancers. So it's not, we're not saying that these are treatments. Melanotan 1 or 2 is not going to be a treatment for cancer, but it could actually have a protective role there.
Mm. And even like, I think we're probably going to talk about this one in another podcast as well, is 5-amino-1-MQ, which is a NNMT inhibitor, so nicotinamide N-methyltransferase, and that's an enzyme that can actually slow down the process at which the body metabolizes fat cells. So 5-amino-1-MQ, small molecule peptide, it's pretty potent NNMT inhibitor. Well, there's some stuff around. Now, I guess one of the things I will say with 5-amino-1-MQ, I mean, that's marine models like rats and mice and rodents. Yeah. So I'm pretty confident that there's no, human trials around that. Okay. So I acknowledge that. But that results in a decrease in like 2 proteins that have been reported to maintain tumor progression. So it was like, it could actually inhibit like cancer cells, and these cancer cells, they generally proliferate at a really abnormally rapid rate. So that's another one. Yeah. Do you want to mention some of the stuff around BPC?
Yeah, I mean, obviously that's one of the big sort of question marks for people. And I think we touched on it a little bit in our gut peptide podcast. And, ultimately, if you were to look at the available data we have at this point in time, I mean, it's a cell study. It's not a human study per se, but we've got studies that do show, a study that shows that BPC inhibited melanoma growth.
It was melanoma. Yeah.
Yeah. And
I mean, obviously it was a preclinical research, and what else did they find?
Well, didn't they find that it downregulated VEGF in that study?
Oh, it's a good question. I mean, I remember some of the stuff around like mitigating muscle wasting in regards to cancer, even reducing like cell proliferation.
Mm.
Yeah.
I
Um,
believe that study found it inhibited VEGF and inhibited
okay.
melanoma growth, which is interesting because obviously the mechanism people are arguing about is increasing VEGF and increasing angiogenesis. And like for me with BPC, I would say, you know what, this is one I would like more data on. Sure. And, am I going to use this in a client who's got cancer? No, I'm not going to. But the available data we've got, if you're going to fall one way or the other, I mean, really, the data we've got is suggesting there's probably benefits there. And
Mm.
like it's only mechanistically that people are bringing up issues. There's no data
Yeah,
showing that it
yeah,
increases
that's the thing. Yeah.
tumor growth. And the mechanism is just around VEGF and around angiogenesis. But BPC doesn't function as a indiscriminate, angiogenic and VEGF upregulating compound. Like, that again, the data we've got shows that it's doing this selectively. So, and I mean, maybe you can
Because
vet.
obviously on that with the angiogenesis, like formation of new blood vessels, they're saying it it would promote the cancer by supplying, tumors with oxygen, nutrients
Yeah.
needed to grow beyond a, certain size. Yeah. Um, and so that's what they're lasering in on. Yeah. Like, that's, that particular mechanism. Um, but actually one like another example I could give, like in terms of like you're sort of like focusing on, a particular mechanism and go, well, okay, well, that mechanism is resulting in this. Yeah, okay. I don't know if I have mentioned this in other podcasts, but this is around TB4, so thymosin beta 4. And so initially in some of the research, okay, they were concerned that TB4 might be involved in carcinogenesis. Yeah. So and I've actually looked at research where it was in regards to thymosin beta 4, like an overexpression and increasing aspects around, cell migration and tumor metastasis and increasing migration of cancer cells. So now, if we look at this, the link that they're sort of uh, sort of focusing on, they say that there's a possible link between the thymosin beta 4 and the process of epithelial what's it called, mesenchymal transition. So I really had to think hard then. Yeah, okay.
Had to go find that somewhere.
Yeah, and so what this is like colorectal cancer invasion and metastasis. So we can look at that, and what they're not looking at the potential benefits of that mechanism. Does that sort of make sense what I'm saying there? Okay, because that mechanism can help with tissue regeneration, wound healing following like injury. And so what it does is sort of bridges the gaps and closes wounds. And so also what we're talking about here is regeneration of epithelial like layers. So we're talking about tissue homeostasis. Now, obviously, one of the questions that would get posed, okay, is that are we seeing the increase in the TB4 as a response to cancer? So is it present in the cancer as an immune response, or is there this actual etiologic concern? So when I say etiologic concern, it's like, is it responsible for illness? Is it like root cause? Okay,
Mm,
investigating the particular agent that might be behind that. Does that make sense? Okay,
mhm.
does that sort of make sense? What I'm saying?
Mm. Yeah, yeah, yeah. I mean, we've used this sort of type of analogy a lot where, is the thing there because it's doing something else, or is the thing there because it's causing that thing? It's like the fire truck analogy. Is the fire truck there because it's
Exactly.
lighting fires, or is a fire truck there because there's something else happening which requires a fire truck to be there?
Mm,
And it's the same thing. Like that's the VEGF argument as well with BPC is VEGF is not just upregulated in cancer. VEGF is upregulated in injuries, right? And just, BPC is not acting by just causing a chronic elevation constantly in VEGF. It has this, basically, it seems to have a synergistic effect when VEGF is upregulated anyway. If you look at cell studies using BPC, when there's VEGF upregulated, BPC basically increases its activity. When VEGF is not upregulated, BPC activity is low. And so this argument that, something like, endometriosis would be an example here where, like endometrial lesions are exacerbated or what would you say, I guess, involved or dependent, I suppose, on, VEGF signaling and angiogenesis. The mechanistic argument people are making is, well, BPC in some situations increases VEGF and angiogenesis. So therefore, in any condition that has VEGF and angiogenesis involved in it,
Mm.
BPC will make it worse. And that is just such a leap to get there because BPC is acting selectively. Now, I'm not saying therefore go and use BPC if you have endometriosis. I think obviously make your own decision there. But we have, at this point, we
But
don't have
couldn't we
any.
make an argument for something like, endometriosis, like around other peptides? Yeah.
Oh, well, absolutely. I mean,
Like
look at how many people,
GLCU, yeah.
well, or even how many people are reporting benefits at the moment using GLP-1s on endometriosis. Reduction in NF-kappa B, reduction in inflammation. So is
Which obviously
BPC,
that would be my argument with some of the GHKCU because it's
yeah,
interferes with like NF-kappa B. Yeah.
exactly. It's doing the same thing. Exactly
Which
right.
obviously we know the link there with like endometriosis implants. Yeah.
Yep. Yeah. Or TA1. We were talking before we hit record on potential. There's, some studies that have, well, a study that is just published looking at a peptide similar to TA1 for potential treatment of endometriosis.
And
So there's,
then you can go further down the rabbit hole with that one because like obviously, the link with women's health ailments and like LPS. Yeah.
yeah, exactly, exactly.
And then
Which is why I don't want to write off BPC because
yeah.
how many people with endometriosis have dysbiosis and have intestinal permeability? And so
Mm,
if someone was concerned, like for me, obviously I'm not ever going to deal with endometriosis myself. But if I was in those shoes, I would probably be inclined to do, if I was concerned about it, maybe do a short period of it, maybe do a short cycle where you're doing an intentional gut healing protocol because
mm,
obviously there can be a strong link there with gut issues, permeability, inflammation, dysbiosis. So maybe BPC is not the kind of compound or peptide you want to be using, 24/7, for years. But does that mean it doesn't mean that it would be a problem if you were. We don't know. But if you want to be cautious, okay, maybe you use it as needed. Maybe you use it for 2 months and that's it.
mm. Yeah. Uh, is there more that we want to?
I think that's probably enough for today, isn't it? Ultimately, our big point is,
This should be a really quick one, yeah, okay. But I know the only reason I want to bring it up because you did have a question around, talking about. I think we could probably cover this one quite quickly. I think there was a question just talking about like, would there be concern around like, endotoxin concentrations in,
yeah, yeah,
uh,
yeah, that was one. Yep.
yeah.
Yeah. So
I
someone
mean,
is asking you around like, obviously the concern is around sourcing peptides. And if you're sourcing peptides that are, maybe not tested, then you could have bacterial endotoxins in them and you might be injecting LPS into yourself and that could be causing disease progression. So what do you want to say about that?
well, one thing I just want to say is, well, understand that, vaccines, there's certain vaccines where endotoxin concentrations, they can be, there can be considerably more endotoxins. Yeah. I mean, you could look at that with things like whole cell diphtheria, tetanus, what is it? The pertussis, vaccine was the whooping cough. Yeah. Um, Once again, I like to put things in perspective. Yeah. Um, I like, I mean, probably it's a question for you. Um, have you come across any information to suggest that there could be some concerns around that?
Concerns, yeah, but in terms of how often is that happening,
Mm,
that data doesn't exist.
mm,
So, yeah, I think this is the kind of example where, do you know what the best way to deal with this potential issue is? Is to make accessibility easier and to remove regulations and stop some of these compounds having to be underground compounds where people are importing them from China and actually make it, make compounding pharmacies able to produce them. Yeah, make it easier to access these. And then you can have a higher standard of, higher regulatory standards if you want around safety, around purity, around endotoxin testing, because you can do that. That's not hard to do. There's
Mm.
places that you can send your peptides off to get them tested. You can get endotoxin testing, right? So is this a inherent peptide problem? No, it's not. It's a problem that, if it is a problem, is caused by just making it harder for people to
Yeah,
get high
just
quality peptides.
pushing it more to the fringes.
Exactly. So yeah, is it a concern? Yeah, maybe. I mean, for me, I'm always on the lookout for places I can get my peptides that are doing endotoxin testing, or I know are manufactured locally in facilities that I have a lot of faith in. So yes, like I don't want to go down the path of potentially having contaminated peptides. I totally agree with that. But is it a peptide issue, or is it an issue that's being created and manufactured because we're making it hard for the people to access high quality peptides?
What? Huh? Uh,
I think that's our cue to end our episode for today. So thank you guys for joining us for another episode of A Peptide Feeling. And we will be back in 2 weeks' time with another episode. I think we still have a couple more peptide podcasts ready to go for you guys. And then we're going to move on to a new topic, I suspect. So if there are topics that you want us to cover, let us know. Otherwise, thank you for joining us, and I hope you'll join us again in 2 weeks' time.